Hello, everybody. On behalf of Neocis, I'd like to welcome you. My name is Heidi Dubois. I am the Business Optimization Manager at Neocis, and I am absolutely thrilled to make the introduction tonight for Dr. Jay Neugarten. He is an renowned oral surgeon out of New York, and he is one of our extra special experts because tonight we are going to talk about the 2-year, very robust study that Dr. Neugarten has done comparing the accuracy of Yomi to all other different treatment modalities. Here we go. Without further ado, the esteemed Dr. Jay Neugarten.
Thank you, Heidi. Welcome, everyone. It is truly a pleasure to be with you all here tonight. First, I'd like to thank Heidi, Gabe, Way, Alone, and the whole leadership team from Neocis for putting on this amazing webinar for something that is really so near and dear to me, that I'm passionate about, and I think all of us are, which is really about accuracy and getting better outcomes for our patients. I'd like to start tonight by starting with a little disclaimer that, and it's self-explanatory, that the material presentation is provided for guidance or illustrative purposes and only should be not construed as a guarantee of future results or a substitution for medical advice from a healthcare provider. Neocis does not practice medicine and assumes no responsibility for the administration of patient care. A surgeon must always rely on his or her own professional and clinical judgment when deciding to use a particular product when treating a particular patient. Neocis does not dispense medical advice and recommends that surgeons be trained in the use of Neocis products and instructions for use before using it in surgery. The information presented is intended to demonstrate one surgeon's use, that would be me. Neocis recommends that a surgeon follows Neocis approved instructions for use before and during drilling. Please contact your salespeople if you have any questions about the availability of Neocis products in your area. So a couple of things from an overall position tonight. Who am I? Why am I here? What is Yomi? And how do I approach, my cases, which Heidi kind of talked about how I've been using this for a number of years now. So who am I and where have I been? I'm an oral maxillofacial surgeon, as Heidi spoke about. I practice in New York City. I have a hospital affiliations at Weill Cornell Medical Center, North Shore. This is my work life and my personal life. Screen left, part of NICOMs, which is 7 clinicians who really focus on tertiary care and oral maxillofacial surgery and really giving people hope and opportunity and really providing high level of quality care. Screen right is my wife and 3 beautiful girls and family, and thank them for the opportunity to be with you here tonight. So I've got my, work life and personal life. This is my staff who I really, couldn't do any of this without them. Their support and photography of these amazing people that really support me every day, to be able to even be with you here tonight as well. And when I'm not in my office, I'm in an academic position at Cornell, and these are my residents that I was with all day today and will be with tomorrow and Friday as well. So the how versus the why, how did I get here and why am I here? Really is one of the cruxes for me. And we as clinicians and we as doctors all have our own bullseyes. And I challenge each and every one of you as you go through your own paradigm, your clinical taking care of it. What do you expect in terms of outcomes? What do you want? What are you looking to obtain? Is it just I want to clear off my schedule and get through patients, or am I looking to get better care of my patients? And how big is your bullseye? What do you want? And obviously, we're going to be talking about implants tonight. But what is your bullseye personally of what you're looking to obtain when you take care of patients? What are your parameters? How do you define your outcome? Is it just a happy patient? Is it just good enough? Oh, it's good enough. Or do you try to achieve better outcomes? For me, I want a better wheel every day because I ask you a question in that your family member, your mother, your father, your child is going to a doctor. And do you want that doctor to just be, it's good enough? It's okay, because you're not going to want that for your family member. So why do we do that for our patients? And I've come across many clinicians and it's like, it's good enough. And that does not work for me. I want better outcomes. I want a better bullseye. And not only that, I want to hit the bullseye every single time. So how do you manage that? Because there's another side to that equation, and that's the patients. They have a bullseye. They want certain outcomes. And can you navigate through that? Do you understand their bullseye? Do you understand? And it's more than just a chief complaint, because I think a chief complaint is a door opener. That's not, oh, I just treated them to their chief complaint. No, because many don't even know what they want. They don't even know their chief complaint. That's us as clinicians that need to drive that. And what happens when you have a patient who you have a bullseye mismatch? You're here and they're here. If you treat them, you're going to have a bad day. And I don't like bad days. So understanding parameters, understanding what they want, understanding bullseyes from an outcome perspective, and then traveling and taking that into the implant bullseye of getting it where you want consistently. And then along with that line, we've developed this CAR, CAR. Can you be consistent? Can you be accurate? But not just once, not just twice, not just three times, but can it be reproducible consistently? Consistently reproducible, consistent, accurate, and reproducible. Are those within your practice? Are those attainable for you? Are those important goals, bullseyes for you? So what is Yomi? What is Yomi and how does it enhance my practice? I saw an opportunity to use technology in my practice to a higher level. Robotics in the world of dentistry, robotics in the world of medicine is clearly here to stay. And so since then, I've been a user, which kind of is what led me to do this accuracy study, which we're going to talk about later. But it has enhanced my practice because it allows me to be more consistent, more accurate, more reproducible across the board. So what is Yomi? Yomi is a robotic platform with planning, surgical and restorative feature that improves the key components for me, accuracy, efficiency, and effectiveness to take better care of my patients. So if we do a little bit of a deeper dive on that, this is what the device looks like. It has a planning station, which is a specific computer that runs the guide arm, and the tracker arm is what connects to the patient. So it has physical contact with the patient. And this is what we call haptic guidance because it's physical. It gives you feedback as well. So it's physical guidance. Whereas you have others that are out there that use cameras. Those are not directly contact. And for those who have used those devices, if there's something obstructing your way, you can't get the feedback that you need. And I use navigation like that in the operating room. But in my practice, in my practice, when I place dental implants, to have this type of physicalness certainly is a game changer for me in comparing the two where I use in the hospital and my navigation surgery and this in the office. So there's three components: the planning station, the guide arm, the guide component, and then the tracking arm. So a couple of indications for use that I have to go through with you technical tonight is that the Yomi robotic system is a computerized robotic navigational system intended to provide assistance in both planning and surgery. And the planning software is proprietary specifically to Yomi. You can't use a different company's planning software along those lines. You can't use it specifically for this device with this computer. The system provides software to preoperatively plan. So all of my cases, all of my patients are planned pre-op, not by me, but by my team. They are educated to do a pre-plan, and all of my patients are pre-planned. But it can even get to the point where I can take care of a patient that day, which we'll talk about later on. But pre-planning is done. And then ultimately, a day of surgery scan is done. And then we marry those two together, the pre-plan and the day of surgery scan, so that we can optimize efficiencies and that planning component. What is it approved for? Well, it's a planning and performed bone reduction as well. Alveoplasty can be done. It can be used in single, partial, and full arch adult patients who qualify for dental implants. It can be used for alveoplasty and implant surgery. When Yomi Plan software is used for pre-planning on a third party, it's a third-party PC. It's intended to be in the phase of dental surgery. So that's the component. Now, what's the workflow? This is a pretty consistent workflow that we utilize. And it's the link, the scan, plan, surgery, and restore. So link is how the patient is physically connected to the robot. Then we have to, the link is what connects them. Then we scan them. Then we plan. or we can bring in our pre-plan. Then we do your surgery and then restore. So what does the link look like? These are different kinds of links, and there really are three kinds of links, two of which are demonstrated here. You have a bone-borne link called a YLB, or Yomi link bone, Yomi link bone. And here's where the tracking arm screws into that little black hole over there. And then the screws are what gets anchored into the jaw if we're going to do a full arch case, or you could even, if you couldn't get stabilization on the teeth with the YLT, which is the screen on the bottom left. This is a YLT. And this is what gets attached to this teeth with this orange material, which is hard. So you have two ways you can attach a Yomi link bone or a Yomi link teeth. And you also have a YLA, which is called a Yomi link arch, which is not in this visual here. But once those get connected to the patient, whether it's to a T or a B, in my workflow, we then put on that fiducial array, which is the black piece on the bottom, which has 9 radio opaque markers in there that allow us to align the X-ray and adjudicate the X-ray to the patient after the scan. So the YLB or the YLT gets on the page, takes on the patient, then we put them in the scanner, and then they come back to the suite. Screen on the bottom right shows you 2 YLBs on, where literally I'm doing a dual arch. So this is a dual arch. And you'll notice that there are upper and lower prosthesis, which is our conversion prosthesis and dentures. And then on that are radiopaque markers to be able to do a dual scan. So we'll do a scan of the patient as well as we'll have an imaging of the prosthesis. So we do the link, which is either a YLT or YLB. Then we scan them, and I have an iCAD in my office. We'll do a scan to be able to get the proper field of view for you. So now we're going to scan, and here's a young man getting scanned in his scanner. You can see the fiducial array on, the YLB is on. We're doing an upper jaw here, and he's going through the scanner. Now we plan. And this is a case that I'm doing with Anthony Salustio. And him and I will then sit down. This is an immediate load solution that we're performing. And on screen right is a single tooth, and you can see we can build in, there's a library of teeth, whether molars or bicuspids or canines, that you can use. Screen left, we are using a dual arch approach where we have the prosthesis in on a dual arch. And this is Anthony and I. Even though we did a pre-plan, we marry that pre-plan with the day of surgery scan, and then we can make adjustments for prosthetics. It is an open platform for whatever implants you want to use. You can use whatever implant system that you use in your practice and whatever drills you use in your practice as well. We're going to get to that. And there's a lot of development that has occurred prosthetically and surgically since I've come on board in 2000, even in the planning realm. I mean, there's been so much innovation and so much technology that has been put into this planning. Even every few months, there's a new release that comes out that amazes me in terms of what's the innovative technology that's coming about from a surgical perspective, as well as on a restorative side to make planning and care better. Now we're going to perform surgery, and this little video, every burr has to be measured and given feedback. So before I do a drill, I put the drill into the chuck, and then I measure it, and I give that to my team, whoever's driving the robot. So I'm doing the surgery, and then I have someone who's putting that input in. And every burr, so this is going to be a Straumann case, it's a 2.2 by typically 23.5. But even though I know the size, because I've done enough, everyone gets measured, and you never assume. And again, whatever drills you want to use, whatever, if you want to use extensions, whatever component, it is completely surgically flexible on that. So now you see irrigation, and you see my sights, and using aligning pins, and I'm drilling the osteotomies to whatever I feel is needed, and I'm getting tactile feedback. So different osteotomies, I will drill till different heights and different sizes. And on this particular patient, we're looking to do an immediate load. So we want to have high levels of insertion torque. So we're under prepping sites, but I'm getting that tactile sense. And you can see the implant is going to torque out right here. That torquing out at 80 Newton centimeters right there. That's 80 Newtons that it's torquing out. And irrigation, again, we use cooled irrigation, and whatever kind of irrigation you want to use, the system will allow that. And then we're going to restore this particular patient. We're using from the particular case, we're using a smart denture conversion. This is Anthony Salustio is doing this conversion prosthesis. And again, it really allows us accurate and precise placement for us to optimize our workflow in the restorative side, which is really the reason that we're doing implants, right? I mean, let's not lose the vision of why we are, because my role is to get the implants in the right place so that the restorative dentist can make the patient teeth. And if it wasn't for teeth, why I wouldn't be putting implants in. So I'd like to go through some cases here to kind of exemplify. This is a woman EP who comes in, 48-year female, who comes in with a fracture number 13. And you could do this in a day, where the patient could come in and they could receive consultation, an X-ray, and treatment all in one day seamlessly, if your practice is built that way, or if you want to build to that. And please understand that my approach to this care has been an evolution. It is not a revolution, right? I mean, this has been now 4 years of a culmination of workflow for me. And my team is the workflow, the whole engagement has really taken to a new level for us just because of the consistent work that we're doing across the board. So we have a number 13 that is broken down, non-restorable. And whether you take the tooth out first and then scan, or scan with the tooth in, it depends upon what your workflow is and what you would like to do. I'm showing you both ways here. You'll see both ways, where the other one that I showed you, the teeth were out. This one typically is the tooth is in. My workflow that I like to do now is I like to get clean surface, and I want teeth out when I can. So I want the teeth out and then scan them. So I'd give local, tooth would come out, the YLT would then go on, and then we put the patient in the scanner, CBCT with the fiducial array. I'm still old school. I'm still OCD. I still take check X-rays. I don't assume anything, right? Because remember this, it's never about the wand. It's always about the wizard. And people love to blame technology for certain outcomes or lack thereof, but it's ultimately us. We can't rely on a tool or a device. So I am OCD in my world. This is my 2.2, and I take a check X-ray, just like I do if I was doing guided or freehand. And she underwent an immediate load, and there's our conversion prosthesis with a pretty nice emergence of that. And ultimately, my restorative dentist will be able to create a really nice definitive crown for long-term prosthetic success and setup. And for me, the bullseye here is, I think we nailed it. And I constantly am assessing my outcomes. Can I do better? What did I do? And even, when we're getting done with a patient, we're meeting my team. What can we change? What can we better? Can we make a better wheel? Can we get better from that case? What can we learn? And that's how we get better. And that's how we consistently hit that bullseye appropriately. And we did a post-analysis, and this is some of the data that came about with the reporting. And this particular implant is 2.29 alpha deviation. And this was an immediate placement. So an extraction and immediate placement, and you're having to deal with scything. And scything is when it hits the side wall and it kind of deflects a little bit. And for those of you that place implants, you know that when you have the burr within the handpiece, there's a little bit of mobility within that. So if you do have an immediate placement within a extraction socket, you can have a little bit of deflection. So having an alpha deviation in an extraction socket of 2 degrees is certainly acceptable result. I would love to get it better, but some of this is related to that slop within the handpiece, but certainly it did not affect our prosthetic outcome for her. This is the next patient that I want to show you, a patient with a non-restorable, hopeless tooth number 9. You can see really no labial plate. This is not the kind of case that I would take out this tooth and do an immediate implant placement. There's no labial plate, so we'll do a delayed approach for her. We take out the tooth. I did a soft tissue graft and a socket preservation, allowed this to heal for 3 months. And now we're looking at our like pre-planned CBCT with a nice labial plate. And if you see those blue halos around the implant, the first blue stands for 1.25, and then the second blue is 3 millimeters of thickness around that. So you can see the trajectory of where we want it to be for a screw retained prosthesis. And I'm leaving nice labial and lingual palatal bone for long-term soft tissue support. We're going to do a temp shell for her. We did the implant placement, and again, nice conformative, no lingual outpouching. I think, for me, this is restorative success, which ultimately is led by surgical success because we're able to really accurately obtain a surgical result that will complement the prosthetic so well for my restorative colleagues to be able to place that. And look at that labial plate. We've got a really nice labial bone placement. And this is a delayed approach for her. And if we look at the pre and post, the soft tissue is really well supported. And again, nice emergence for the restorative dentist to be able to ultimately place a screw retained prosthesis. And that's her post-operative result. I'm now going to pivot and we're going to look at a partially edentulous patient, not only partially edentulous, but someone who's got pretty severe atrophy, broken down teeth, limited posterior vertical bone in the right maxilla, and as well as in the left maxilla, and edentulous in the mandible. This is the view through the sinus, and you can see 8 millimeters, but even as you come to different areas, there's about 2 to 3 millimeters of bone that's there. So can I do sinus lifts and immediate implant placement? And the answer is yes, and we do them all the time. And people look at this and say, well, how are you going to be able to do that with 2 millimeters of bone? And it's not a matter of how much bone it is, it's about the quality. And I will tell you that about 99% of the time, I will do a sinus lift with an immediate implant placement, especially with having the Yomi in my hand, because it gives me a more precise, accurate osteotomy that I'm able to get pretty high levels of insertion torque, even with bone that shows 2 to 3 millimeters. I did a case this week with 2 millimeters of bone, and I was able to literally get 70 newtons of insertion torque on 2 millimeters of bone. Obviously didn't load, but I just want to make sure it's not a weeble wobble, then I would take the implant out, which is really not something that I typically see or haven't seen in years utilizing this approach. So this is our plan. We're taking out 4 and 5. We're placing in implants in the right maxilla, 2 implants. We're going to do a sinus lift in right and left maxilla, and then multiple implants in the mandible. And we'll need 2 YLTs. We'll put one in the anterior maxilla and one in the anterior mandible. And the YLT, they have directionality to it and they have location to it. So they have upper jaw, lower jaw, upper left, upper right, and anterior, and the same thing in the mandible. And the YLB has right side, left side for both the maxilla and the mandible. And this is fully will come supported. We have a full complement of it. Depending on what we're going to plan for that patient, will ultimately determine what we'll use. So here is some videos now showing screen left shows the sinus lift that I'm performing. So the first thing I'll do is make a flap and then elevate the sinus. And then I will go ahead and prepare my osteotomies. And if I'm putting a 5.5 by 12 millimeter implant, and I know that the bone is only 2 millimeters thick, I'll only go into 4, and I can control that osteotomy de novo. So we'll move the implant down. So I'm only in 2 millimeters. I'm not burying it, and I'll stop, and I'll get a hard stop. So it limits me from depth. So if I have a sinus that's 2 millimeters thick, I will move the implant 2 millimeters in, so 4 millimeters from crest, and I'll drill that once I've got my sinus membrane elevated. Can you do an internal sinus lift? Absolutely. Do I do internal sinus lifts? Absolutely. I will do it with my VersaBurs. I love that. I'll do them on ostensification in reverse and go up. This is a great complement for that. This particular situation I'm showing you, though, is a lateral window because of only having 2 millimeters of bone, and I need to elevate it. You can see the bone going in, and then there's my implant being placed. And again, torquing out with high levels of torque right there at 80 newtons, because I That's where it goes in at, and that's where it was trying. And then screen right is when placing the bone in. And one thing I'd like to show you guys here is as you're watching this video, my eyes are on the patient, and there's a lot of auditory feedback that is given to me. I am not operating looking at the screen. My eyes are on the patient, which is a little bit different from using augmented freehand or some of the camera-based systems where you need to look at the screen to be able to make sure you get where you need to be when you're drilling so that you don't come off angle. But when I'm using the robotics and I'm locked on, I am not going to be deviated. And an analogy I give is like being on a railroad car, where I'm just going up and down, depth control, and there's a lot of auditory feedback. So this is the postoperative CBCT on the patient. You can see the three implants in the right maxilla through a sinus lift, the two on the left, the three on the left mandible. I took out the implant in site number 21. I did not place that. At the time it's grafted, he's going to be having that placed probably in the next few months, as a matter of fact. And then the three implants on the right mandible. So now I want to jump into full arch workflow, which again, my workflow changes. And that's one of the flexibilities for me. I'm constantly looking for a better wheel, a better habit trail. And working with robotics allows me to do that because the technology continues to grow and grow and grow and grow and get better. I mean, look at the technology that we saw a couple of weeks ago with an unmanned spacecraft from SpaceX going up 50 miles into the sky and then coming back and landing with on a station. The spacecraft landed on unmanned. I mean, the technology of that, the innovative of that it's unbelievable. And as you begin to bring on new technology and new innovation, we're constantly looking for a better mousetrap and constantly moving our cheese. My team and I do not get complacent. And that expansivity, that expansion is what allows the engineers with Neocis to do that. And it allows me to continue to grow and develop. So we're not stuck in the mud with this and constantly developing new workflows. So my original workflow completely has changed from where I first started in 2020. If I look at where I was and where I've gone through, a lot of that is just because of the innovative technology. Couple of things. This was my prosthetic workflow: temporary cylinders, smart denture conversion, and now we've gotten into the world of photogrammetry, ICAM, and milling and printing. I no longer use temp cylinders. I'm now in a smart denture conversion in the photogrammetry using milling, and we pre-milling the teeth even with the technology that we've gotten today. And I'd like to use this case as an example. Edie, 58-year-old female, who desires a fixed solution. She has a complete upper denture, and she has a calculus bridge on the lingual aspect of those lower teeth. And we look at her panorex, you can see these are really periodontally involved, perioendo lesions, and non-restorable, not sustainable. So our plan on her is a dual arch. In the maxilla, I'm going to do zygomas, which were not placed robotically. That was a freehand direct visual. And in the mandible, we're going to do an all-on X, but we're going to do a dual scan on her. So terminal dentition with severe atrophy. The treatment plan, like I said, conventional implant therapy with an immediate load. And this is a case also that I did with Anthony Salustio. And you can see the dual scan on the screen. So we place the YLB. You can see the YLB below the green. And we're planning off of the pre-plan we did. And then we're aligning the teeth, the implants to get it in the proper place prosthetically. Because again, to reiterate what I was talking about earlier, the only reason I'm placing these implants is for my restorative dentist, for Anthony. And I need to make sure that I optimize the tooth position, the implant position, so that he can optimize what he wants. And having him there, and he's giving me feedback, and I'm giving feedback, and we're adjusting things as we go. And I can even do this in surgery, which I will adjust. And you can see he's giving feedback to me right there that what he wants in terms of what he's looking at for his prosthetics. This is the suite. Here we have a patient that's being done under general anesthetic. My whole team, the anesthesiologist is there. The Yomi robot is sitting in front of you. That's Will, who's one of the technicians. And I thank you, Will, if you're on tonight, for all the hard work that you do for me and my team. You're amazing. And Anthony and I are looking at the screen and planning what we need to do and moving things as we're getting ready. Here is a duplicate, and even on my full arch patients, I still trust nothing. If they're all the implants and everything I do, we take the conversion prosthesis, I clear duplicate it. We have all the aligning pins, and Salustio Anthony will look at this and say, yeah, I like everything, and this is in the 2.2. I can make adjustments if I need to. And you see the YLB sitting there below with the screws, and those are 2.0 by 18 or 20 millimeter length screws. And I only need three at a minimum. There can be more. There's a total of 8 spots that I can put those screws into. So if one of the screws would be in an area where there's an implant, I can move them around and pivot and do-si-do in the middle of surgery to not have that as a problem. Um, this did not require any bone leveling. If I needed to, there's a bone leveling module that is a straight handpiece that I can place on to be able to bone level. And that to me has always been it's a bizarre feeling because you feel like you're in like the vortex. I feel like I'm in sci-fi. I feel like I'm in a box because literally you'll hit a wall when you try to use the bone leveling handpiece. And it's you can pick your plane and your depths of where you want it to be. But getting back to this patient, this is the duplicate with the aligning pins in place to optimize prosthetics. Um, and we're going to use the smart denture conversion again for her. There's my sutures closed. And sometimes I can do these flapless, depending upon my attached tissue. On her, I was taking out teeth. And we planned 6 implants on her. There's the conversion prosthesis. And look at the access holes and look at the positioning of them. Screen right is the plan. So that's the CBCT overlaid with the dual arch scan of the prosthesis with the 6 implants, with the aligning pins coming through. And then screen left is the actual prosthesis. And certainly very, very consistent with what Salustio would like to have from a restorative perspective. And I'm pretty happy with what we're able to accomplish here. So this is the CBCT. Um, Obviously, the zygomas in the maxilla, but that's independent of this. And the CBCT, you can see the bone holes where and the symphysis of where the YLB was held on to, which is below the apices of the teeth. And there's a tilt on the YLB that allows you to get further apically, either in the maxilla and the mandible, so that we can, again, navigate around the apices of the implants. This is ED's soft tissue with the SRAs in place and really healthy tissue. The bone level is optimized, no change. In this case is now about 2 years old. Really healthy. Anthony took off the prosthesis for me. Her hygiene has been impeccable. Soft tissue is well supported. And it really starts with, top to bottom, diagnosis, treatment planning, working together collaboratively. And, certainly having the accuracy, the predictability, and the consistency gives me both surgical happiness, but prosthetic success for me and for the patient. So now, we've gone through this whole paradigm of various modalities of how I use the robot. But one of the things that I said to you earlier was about a bullseye, not getting complacent and make it better. So now, having done this, I said, look, how good am I? How good is the robot? Like, where are we with this? Is my outcomes, what we're seeing, truly synergistic? Does it match? Which is what led me to do a retrospective study to look at the outcomes of implant positioning where I want it versus where I ended up with robotic guidance. And that's why we did this scientific study. So, and this was an article that got published in the International Journal of Oral Maxillofacial Implants earlier this year. We can give you a copy if you'd like and request it. That's a picture of my dad. My dad does have a implant. He passed away this year. But he did happen to see that I put him in my article, and I really thank him for giving me the opportunity of being who I am today. But I had to put my dad in my article because he has a robotic implant. He never stopped talking about how he had a robot place his implant. But so the study design. The study design was 108 implants, um, looking at 273 implants, whether they were singles, whether they were doubles, whether they were full arch. We did not exclude. Whether they were extraction and immediate implant placement, we did not exclude. We just took 108 patients, 273 implants with no um, exclusion criteria. That would there were some exclusion criteria, but that was not one of them. And it was a 2 year. We looked at this over 2 years. So we looked at implant distribution. We did a preoperative plan. We did a day of surgery plan, and then we did a postoperative assessment. So we took the preoperative plan, overlaid it onto where the postoperative implant outcome came, and then we looked at various parameters. And this is what we looked at. We looked at the coronal depth vertically. We looked at the angular deviation, the coronal overall global, and then we looked at the apical differences. And what's glaring to me was we had an alpha deviation of 1.4 degrees. So what that means is this was the axis of where I wanted the implant. And the implant, in terms of its trajectory, came off 1.42 degrees off from planning. And pretty consistent. We had a standard deviation of 1.53 degrees was our standard deviation. Our max deviation was up to 6. Minimum was 0. We had some that were exactly on. Our interval of 95% confidence interval was 1.6, and our lower confidence interval was 95%. So I would say that this is pretty remarkable for me. But we said, okay, well, how does this compare to the literature? What's in the literature? So that's what we did on the bottom. With a mean confidence of 95%, we looked at this study, which was 273 implants. And as I said before, we had an alpha deviation of 1.42 degrees. So we looked at the Thomaseb study from 2018, which looked at over 2,000 implants. And this was a static guide. And they had alpha deviations of 3.4. Schneider, using a static guide, 5.26. And then the last study was 3.8. But so now let's go one step further. And we looked at the standard deviations for angular deviation. And we compared this to the Cassetta study as well as the Block study and the Schnutthaus study. The angular deviation of 1.53 degrees, again, was the narrowest amount of standard deviation across the board between static guides, freehand, dynamic, which is the augmented freehand, which is the XNAV, which is what they looked at. So what were the key findings? The key findings showed that the robotic or haptic guidance outperformed freehand, computer guided, and dynamic computer guided, all three. So freehand, static guides, and dynamic computer, which is the XNAV. And some of the parameters were mitigating skiving and wandering of the drill tool, which is what I was talking about earlier. And does this lead to a better outcome against implant placement of vital structures, the nerve, the sinuses, such and so forth and so on? And when we look at the potential explanations of why haptic feedback combined with visual guidance provided real 3D constraint. So we're really getting 3D data at that time to be able to adjust. And the elimination of the fulcrum effects, being static guides, where as you're coming in, it's kind of bending. And you also have that in augmented freehand, which is the XNAV. And as you're coming in, you can't stay here. You're kind of tilting. And one area that I really didn't even discuss, which I think has been a game changer for me, is the second molar, whether it's in the maxilla or in the mandible. But maxilla is really difficult sometimes, where you have a patient where you're trying to get back and they're fighting you. And often your implant will come out to the buccal. Well, why did it buckle? Because it's easier to get there. But when you're using the robot and the Yomi, you have to get to that spot. And one of the innovative and technological advancements that has come about is what's called lateral access. And if you have a patient who has a limited mouth opening or limited interclusal space and they can't get to it, you can start from a really off angle. And as you come in, it rights you the ship. And using short burrs and using lateral access has been such a game changer for me. I'm using that all the time to be able to get into tight areas with this piece. So the implant comes in off and it's a lateral access and it uprights the implant as it goes in. So in closing here, as we're starting to wrap up our seminar, and we'll open it up to questions. Again, we're coming back to this consistent, accurate, and reproducible. This car. How do you look at your car? How do you look at your patients? Can you be consistent? Are you accurate? And are you reproducible in your care? So I'd like to open it up to questions now to the audience, and it certainly has been a pleasure to be able to give you my insight into this paper and accuracy and reproducibility.
Thank you, Dr. Neugarten. That was absolutely fantastic. And the questions are starting to come in. Please type them in the chat. I'm going to go ahead and read the first one. So for your full arch cases, are you running into situations where your bone fixation screws hit teeth of the planned implants?
Yeah, so we'll see that on the plan. The answer is yes, but very rare. And a lot of that has to do with how we're placing our YLB, so a Yomi link bone, and controlling that angulation and staying down in the mucobuccal fold or up in the mucobuccal fold in the maxilla and really pushing that out of the way. And with the pre-plan that we do on Yomi Plan, we have the ability now, which was a new technological advancement that came about, to put our Yomi link bone in. So we can see how we can strategically plan and what screw axes to pick. So it can occur. It's rare. And if it does, we have 8 access spots. So if we go back up and we look at the Yomi link bone here, I can pivot and I can adjust to, here it is. I can adjust. So we have 1, 2, 3, 4, 5, 6, 7 here. And if I'm using number 2, 4, and 7 is once in my implant, I can move 7 to 6 to kind of get away from that interference if it does happen to exist.
Fantastic. Thank you for that. The next question is, are you placing all of the bone screws with the robot?
No, the bone screws do not get placed with the robot. I'm sorry if I didn't make that clear. The bone screws get placed freehand. There is a YLA, which you can place it with the robot. The YL arch, Yomi Link arch, is a horseshoe arch, which when you can place that and kind of obviate that. But in the Yomi Link bone, the screws are placed with a straight hand piece and a burr that's 20 millimeters long, and you go through the mucosa, through the alveolus, and then you screw in this 2.0 by 16, 18, 20 millimeter length screw into that osteotomy that you've created.
Great. Thank you for that. And I want to remind you, please type your questions in the chat, and we are going to relay them all. So here's one. I love this. Hi, Dr. Neugarten. Always great to hear you speak. I'm a Yomi user and an oral maxillofacial surgeon. I continue to struggle with multiple implants next to each other. I am never achieving the bullseye, say 3 to 4 millimeters between implants. Do you plan these differently? At this point, I continue to take the 2 millimeter radiograph, but sometimes that is a bit too late in terms of adjusting the location.
So 2 things. You can come spend some time in New York. Please come. I'd love to have you and go through that. But I think I have not had that experience where having the implants placed, but I certainly do use my aligning pins. But again, understanding, I think as you use, kind of like what I was talking about earlier, is I'm constantly assessing. So when I come into and I'm in freehand, and if so you go free and then you go into guided. And when I'm locked on, and locked on mean I'm in the proper trajectory of that planned implant, I'm looking and I'm seeing where I am. And sometimes I'm like, you know what? I want to make an adjustment. And I will take my mirror and I'll look and see if I'm right in the middle of the teeth of where I want to be. And I'm pivoting and I'm adjusting to making sure that I'm optimizing those positions to get that bullseye more consistent.
Thank you. Next question. Great presentation. Do you need to adjust the pre-plan for flapless surgery? Also, do you see less swelling discomfort with Yomi?
Yeah. So I do a fair amount of flapless when I can. And yes, less swelling. Yes, less recovery. Yeah, all of it, yes. Just because, again, you're not making that flap that you need to make. Sometimes If I'm unsure, I'll make what I call a little peekaboo flap. I'll take a 15 blade and I'll just make a little reflective over that if I'm unsure in terms of where it is. But I do really not have to adjust unless, again, I'll take my spear. I have a spear burr and I'll come over the mucosa. And I want to make sure that when I put that burr in the attached tissue, if I'm going to go flapless, that I have good soft tissue on either side of it, right? So I want to make sure that I have good attached tissue on the buccal and on the lingual. If I don't, I might make a small crested ridge and reflect so that I can keep that tissue, because ultimately we will lose some of that with the osteotomy. So yes, it's been in those cases that in those patients that I can take care of in a flapless approach, I always want to. Yeah, for sure.
Great. Thank you. And the next question. Hi, Dr. Neugarten. Thank you for doing such an excellent presentation. I just purchased a Yomi and it's scheduled to arrive in my office on Tuesday of next week. Congratulations.
Congratulations.
We're happy to have you. Can you tell me about Yomi, how Yomi can be used for angled implants that are often utilized in all-on-X cases?
Yeah, great question. So it's a learning curve. I'm super excited, and again, I'll help you. I can be a support for you anytime if you want to reach out through the Yomi family. But the again, the all-on-4 back implant, when you're going to tilt, you can look at the angles. It has an angular measurement and a ruler that comes in there that you can optimize, and then it has the built-in SRAs or multi-unit abutment, depending on what implant system you use. So you can plan all of that in your pre-plan. And again, getting back to that angle, as we know, sometimes can be difficult. But using the Yomi, you have to be there. So I love it for my distal implants on my all-on-4. It really helps and supports that, and using the different length burrs, short burrs, medium burrs, and having that full access. And if you use Versa, again, it's fully capable. So it's from a treatment planning to a execution and a prosthetic component. It really helps you. And many times, my team, we are not even re-angulating those distal implants. So we'll put in many times, okay, well, you put those posterior implants in and you're going to put a 17-degree angulate. We're going straight. We're not even putting on 17 degrees because of the short cap on the SRA and that we're using, depending upon the restorative dentist. Some want to re-angulate and some don't. So certainly that's something that we can optimize by working, getting proper angulation to help you with that.
Great. And thank you again, everybody, for the questions. I know we have a lot of questions here. We have time for one more because we do want to be respectful of everyone's time. Please reach out to your Yomi support and we can get these questions answered for you. The last question.
Can I answer one thing on that, Heidi? Well, I'm going to answer.
Sure, please.
If you guys, you can DM me at Dr. Neugarten. You can email me the questions. I will answer your questions, please. If we're short on time, I will be here for you guys either through either of those two ways, or Yomi can send them to me and I can get answers to you.
Dr. Neugarten, you were absolutely fabulous. I want to thank you from the bottom of my heart. I love every single thing about this. It was great. And thank all of you for joining us this evening. I want to add a couple housekeeping notes. First and foremost, we will be, if you would like a copy of the study, please let us know. We are happy to email that out. I saw a couple of people ask for that in the questions. Second, we are going to be sending out a very brief 1-minute survey after this webinar. As Dr. Neugarten said, we continue to bring education to you. We want to know what you liked, what we could do better, and really what you're looking for so we could keep both new users and our longtime customers continued up education and on top of everything that Yomi has to offer. And as we grow, you grow. So we're really looking forward to that. So everybody, thank you very much. Dr. Neugarten, have a fabulous evening.
It's been a pleasure.
And I wish you all a good night. Bye-bye.
Thank you, everybody. It's been a pleasure.